Welcome to the Tennessee Heart Health Network webinar. Our aim is to be your resource for innovative statewide initiatives to improve primary care for all Tennesseans. We hope that you enjoy today's educational program and share it with your colleagues to make a better impact of heart health in Tennessee.
Thank you, everybody, for joining us here today. My name is Ashley Ellis. I am the Director of Practice Implementation for the Tennessee Heart Health Network and Population Health Consortium. And I'm also Assistant Dean for Strategic Partnerships and Innovation at the College of Pharmacy at UTHSC on the Memphis campus. So I'm very delighted to introduce our speaker here today, Dr. Christy Wick. Her background is extensive, and she joins us from the University of Tennessee, Chattanooga, and their College of Nursing. So she has her bachelor's and master's degree and doctorate degree in nursing, and she has done, as I mentioned, extensive scholarly work. She has been awarded over $1.5 million in grant funding to help through dementia-friendly communities. She is the Vicki B. Gregg Chair of Gerontology, and she's an assistant professor. Her goals are to advance the care of older adults through community collaboration, ensure a capable health workforce, and to conduct research to guide clinical practice and community health. Recently in 2020, Dr. Wick received an appointment by Governor Lee to serve on the Tennessee Commission on Aging and Disability for a term of 5 years. And that includes working on a legislative subcommittee. So it sounds like you're very busy, Dr. Wick. So we're very glad that you're here with us today and sharing your time. And she's going to be speaking about shared decision making, advocating for what matters most. And I know that all of you will enjoy her information that she's going to share with us. As always, we do want our learning collaboratives to be interactive. If you have any questions, I'll be monitoring the chat, and we'll have time for questions at the end as well. And I'm sure Dr. Wick will love to answer those. So I'll let you take over.
Thanks so much. Hey, everyone. I am so excited to be here. I'm going to get my presentation started, but while I do that, I wanted to just offer a couple caveats. The first one is that we are all aging. It's one of the most common threads that binds us all together from all walks of life. If we have a heartbeat and are breathing, we are all aging together. And today I hope to share some insight with you about shared decision making for our aging population. But I also wanted to just acknowledge that I'm not necessarily talking about one discipline or one discipline. So I know all of you come from different areas of expertise and training. And so I think that we will have enough discussion that you'll all be able to take something home from this presentation. At least that's the goal. So as Ashley mentioned, I am hoping this will be interactive. I wanted to start with the first question, which is how old is old? And if you would enter your answers into the chat, that would be great. I'm going to start with a little bit of data, and then we'll go back to that and talk about it here in a second. All right. So as I mentioned, we're going to talk about older adults and caregivers. I'm going to introduce age-friendly healthcare and talk a little bit about the importance of interprofessional collaboration and shared decision-making. In Tennessee, 25% of our population are older adults age 60 plus, and that's really for 2030. Right now, we're hovering somewhere between 20 to 22% in most counties. So on average, we're expecting our population of older adults to be 25% by 2030. Currently, 38% of our older adults are living with a disability. In Tennessee, we have 37 board-certified geriatricians, and we need that to increase by 827% by 2050 for us to provide the care, the quality care that's going to be needed for all of us as we age. 39% of us live in rural or underserved areas, and Tennessee ranks 42nd for the America's Health Rankings Senior Report. I would be remiss if I didn't talk a little bit about dementia and caregiving, just to continue to promote awareness and try and decrease some of the stigma around dementia and memory loss, and then to help bolster our workforce and awareness for caregivers. In Tennessee, we'll have 140,000 people living with Alzheimer's specifically by 2025. That's a 16.7% increase in 5 years. If you think about the population increasing, it makes sense that we would also see an increase in our persons who are having some trouble with memory loss as well. One of the big keys is that for every person living with dementia or some type of memory loss, generally speaking, in the moderate to severe stages, they need up to 4 caregivers to help take care of them. So that's one of the most important reasons that we want to focus on caregivers as well when we think about our health structure and our resources in our communities for older adults. Currently, there are 369,000 people who report being caregivers of persons with dementia. There are many, many, many other kinds of caregivers that we have in the state. People who are taking care of children, people who are taking care of children and older adults, but this number has to do with those who report taking care of someone with Alzheimer's disease. That equates to about 499 million hours of unpaid care, which is equal to $7.8 billion in total value. 67% of our caregivers report chronic diseases, over 30% report depression, and 17% report poor physical health. So it's important that we acknowledge caregivers and some of the barriers that they have to accessing good health care. Many of you have probably seen this. It's one of the most common slides I think that I see in all of the presentations about older adults. It's because it's so significant. In the year 2035, we're going to have a shift in our population where adults older than 65 are going to outnumber our children. And this is pretty important when we think about that caregiving number and how we're going to help support those who need a little bit more assistance to age in place. This graphic is a little bit different, but it's very significant. You can see by 2030, the amount of older adults compared to those who are younger. And just thinking about how that's fallen over the course of the last couple decades, it's significant. All right, so back to that question, how old is old? Let me look through here. So many of you said old is in the mind or has no number, certainly over age 65. It's objective, personal, different perspectives. People are living longer, and those are all completely valid points. When I see someone in practice, I really don't need to know a person's age with the exception of their date of birth to verify who they are, or if I'm trying to think through what resources might be available in the community. Age is a function of our health and then our ability to function, to get through our activities of daily living, and the ability to do the activities that we enjoy. So there's really no specific number when we talk about older adults. There are people who I've seen in practice who are in their 80s running marathons, and then there are others who are in their 30s or 40s and are fully dependent on caregivers to get through their day. So those 3 things are really what we try and focus on. However, when we're talking about data, generally speaking, we're talking about 65 and older because that's the Medicare population. If we're thinking about senior centers or older adults, federal funding, sometimes that number drops down to 60 plus. And then even further, sometimes we'll get into the 55 plus for some other kind of community resources. So it's important to think about age in the context if you're thinking through resources and data. But when we're talking about the individual and what matters most to them, there really is no age that makes them an older adult. I wanted to start off by talking about aging in place because 73% of people over age 45 desire at this time in their life to age in place. That's the ability to live in one's own home or community safely, independently, and comfortably, regardless of age, income, or ability level. Most notably, 88% of older adults report wanting to age in place. And we suspect that care will be needed to be provided by formal or informal caregivers to make that happen, which requires us not only as individuals, as families, as the healthcare system, but in our communities to develop an infrastructure and plan so that we can help people achieve their wishes for aging in place and staying in their homes as long as possible. And that really just requires maximizing their quality of life, their maintaining their independence, things like that. Older adults are just as prone, if not more so, to the social determinants of health. Many of you, I'm sure, have all heard about the impact that the social determinants of health have on each of us and our health status. Older adults struggle with transportation and accessing services, or even just accessing food. Older adults are having more and more trouble with housing, finding affordable housing or housing that is in or near an urban area that has resources that they need, including access to healthcare, medications, housing that's safe, housing that has air conditioning, housing that's warm, housing that has modifications so that they can have some of the adaptive equipment that's needed if their body's failing them in some way. We're all feeling the strain of the expensive food these days, and we promote, all of us on some level, promote healthy eating, a good diet, lots of greens and bright colors and things like that. But food is expensive. Food is hard to get to. Many people live in food deserts, and that especially goes for older adults as well. Not only is it hard to access, but it's hard to prepare. So there's lots of chopping, lots of fine motor movement, lots of storage situations that happen. So food seems like it would be not any more difficult for anyone else, but it really can be challenging for older adults as well. And then shopping, just getting out and getting things done, getting the items that we need to go about our day, not necessarily at a big, pretty mall, but anywhere. Just that ability to get around town can sometimes be challenging. Many people depend on a caregiver to help do that for them. So going a little bit further with older adults concerns or barriers or challenges, we've got major workforce shortages, just like the rest of the United States and the world, really. Tennessee is not any different than anywhere else. We know that our older adults have 42% have more than 4 chronic diseases, which is very high. And there's a cost associated with that, along with a level of disability and need for support in the home. We're also watching this dementia and caregiving crisis that is coming as our population ages. A lot of people struggle with ageism. I struggle with ageism when we see or hear things in the news or on the media or social media that describe aging as a bad thing. We're really trying to flip the script and show what it means to age actively, age successfully, really hone in on the qualities and strength and wisdom that older adults harness by having lived as many years as they have. And then, of course, we just have this population growth that sits out there, so we know that that's an issue. But we want to try the best we can to build that structure to help stave off some of these things. So I just wanted to give you a brief history about age-friendly healthcare and then how that ties with interprofessional or multidisciplinary care. People call it different things. This is a very busy timeline. It's meant just to show you a couple themes here It has a couple different color codes, and all these slides will be sent out after the fact along with a reference list that ties to each of these items. But way back in 1999, there was the National Academy had a committee who convened and wrote a big report called To Err is Human, Building a Safer Health System. And that had to do with quality of healthcare and really centered a lot around infection control and inpatient quality. So making sure that people who are going to the hospital are getting safe care. The next big report that came out was called Crossing the Quality Chasm, and it really focused on 6 different tenets for good quality care. One of those being person-centered care. The others were safe care, timely care, that we each have a right to good quality health care. That was followed in 2008 by looking at some health workforce issues. And then we started seeing other institutions kind of creeping up with different things around aging. For example, the American Geriatric Society started really looking at this idea of team collaboration or multidisciplinary care and education for healthcare providers, that each different discipline should have some type of competency for working with others, on a healthcare team. And then in 2009, the Interprofessional Education Collaborative was formed, and they spent several years over that next decade working on a report for interprofessional and collaborative education and practice. And a lot of their information and competencies are what helps inform some of our teaching today and our healthcare. At the same time, the Institute for Healthcare Improvement was talking about the business aspect of quality. So really still kind of pulling from that early report and To Err is Human and then Crossing the Quality Chasm. They started talking about different aims, the triple aim, the quadruple aim. It's now the quintuple aim. I'm sure it'll be something else very soon. But that really is still a pathway focused on systems improvement, quality of care, and looking at things from a hospital provider and patient satisfaction perspective. And then over the past, time is going so fast, I guess 20 years now, 15 years, we've had this evolution of what it means to be an age-friendly community or dementia-friendly community, age-friendly healthcare. Different institutions have contributed to that work. The Institute for Healthcare Improvement for sure, but also Trust for America, who's working through the Age-Friendly Public Health System, the John Hartford Foundation. So several different works have informed what now we see as an age-friendly ecosystem. And so one of these reports way back when I left from the timeline in as a slide because it really boils everything down to what we try and focus on with healthy aging, which is promoting health, preventing injury, and managing chronic conditions. Obviously, we want to optimize our cognitive health, our physical health, our mental health, but they actually make a full domain about facilitating social engagement. It is so important for all of us to remain engaged in some sort of social activity and seeing other people. And we learned a lot of that through COVID as well. There is an American Geriatric Society white paper on healthy aging that summed up those domains that I just showed you, but also talks about the different pillars of gerontology, or the study of aging. And they named educational, clinical practice, research, and advocacy. And then one of the pillars that I believe, my little opinion, is that we should always add community in there, because really that's where the boots on the ground happens. That's where all of you are out trying to do the good work of supporting older adults and facilitating all these other things in the process. This is just an example of the quintuple aim. It says quadruple in the middle, but it has that little box for equity on the side. This is what started as the triple aim and then morphed by adding a provider experience, trying to come up with ways to reduce burnout. And then they added later on that piece of equity, which reflects our concern for the social determinants of health and equal access to care. Finally, this is an example of the age-friendly ecosystem. And as you can see, there are different segments of that. One being public health. We want to work on age-friendly workplaces, home and community-based services. We want our cities and states and communities to have the infrastructure for everyone to age well and successfully in the city, community, neighborhood, home where they live. And then also education and research should reflect our goals for age-friendly health as well. And up in the top left at like the 11 o'clock is our healthcare systems for age-friendly healthcare systems. And that's basically where we're going to spend our focus today. So age-friendly health systems aim are to follow essential sets of evidence-based practices, no matter what discipline that you're practicing, to cause no harm and to align with what matters most to the older adult and their family caregivers. And keep in mind that this can be applied, again, through pediatric care or cancer care or any type of care that's being given. But for our purposes today, we're talking about, obviously, the age-friendly. We're talking about what matters most to older adults and their caregivers. So the principles of age-friendly care include that patient-centered care, caring for the whole person, coordinating and integrating care, so that interprofessional team approach, making sure that services are accessible, and then evidence-based practices. And this is, I'm a visual person, I love schematics, but this really helps dial down exactly what we're looking at. And for those of you who were trained in the healthcare model or the health model of assessing, doing physical assessment or prescribing medications, all those things, there are different things, different, past medical history and review of symptoms and all those things that we've all been taught. But if you think about the care of the older adult, it really boils down to these 4 categories, and they've added another in there called multiply morbidity. And then they're also acknowledging caregiving as well. They just haven't changed their schematics much. So what matters most is what we'll focus most on today, knowing and aligning that care with each older adult's specific health outcomes or goals. It's including but not limited to end-of-life care. We think about what matters most a lot when it comes to end-of-life care, but really what matters most can impact every single touch point in a person's health journey. As we go, we'll talk a little bit about medications, mobility, and the importance of mentation and making sure that we're covering those, but we'll do that in a little bit. So just one last time talking about that interprofessional team approach. It's part of that patient-centered care model. The concept is that when providers each consider each other's perspective and work as a team, and they include the patient and or the caregiver, we deliver better care. And this includes clergy, nutritionists, the dentist, the podiatrist, the community health worker, the social worker, nonprofits who may be providing, or for-profits, someone who's providing transportation. So all of those people are considered part of an interprofessional team. When we all practice at the highest of our skill levels, we have better patient outcomes, better patient satisfaction, less provider burnout because we're all kind of sharing the responsibility. And it also contributes a lot to being able to age in place. So the more that we can use that interprofessional team approach, the more people we find are able to remain home and remain as independent as possible for as long as possible. Long-standing challenges of interprofessional care come with fragmentation and silos. So think about different hospital systems, think about different practice groups who are within the hospital system, and trying to get all of those people in a team without power struggle or without financial implications. And part of that is there's a lack of reimbursement models for this. So we're getting better. The new CMS guide program is really working towards that interprofessional team approach. But it's taken a long time to even get to this point, and we're certainly not all the way there yet. I just threw this in here as a reminder what the interprofessional competencies are. Those include knowing your roles and responsibilities, communicating well, working with shared values and respecting the other team members' values, following your ethics, and then obviously applying team values and teamwork to your situation. Team-based care is obviously very helpful for care for people who have serious illness or complex illnesses. There's no gold standard for getting a team together, training, and building that sustainability for strong interprofessional teams. Although, as time goes, we're seeing more and more evidence out there for establishing some of those gold standards. There's something called complexity science, which talks a lot about team-based care, but it's a little bit over my head. So I just wanted you to know it was out there. So this is another opportunity for you to put some things in the chat. I'm wondering if you could handpick an interprofessional team or multidisciplinary team to provide care for others. If you were part of an interprofessional team, what disciplines would you include? What type of role or other people in your field would help you the most serve your clients or patient populations the best? And if you'll just put that in the chat, that'd be great. So I'm going to introduce shared decision making, what the benefits are for older adults and caregivers, the process, some barriers we'll talk about, and then also a couple of the decision aids that we can use. On that first marker of age-friendly care is the what matters most, and it really is the most important piece that drives all of our complex care with older adults, or it should. It's defined as what matter as knowing and aligning care with each older adult's specific health outcome, goals, and care preferences, including, but not limited to, that end-of-life care. I want you guys to think about what matters most to you, because this is really the part of the key elements. It's how you feel. So while we're going to work on how we work with our clients and patients about what matters most, it helps to start with what matters most to you. So sort through in your head your own health status and trajectory, your own fears and concerns, your own values and beliefs, family values that you carry with you. Think about your own health goals, your own care preferences. And I've used several analogies along the way as I talk about this with students or with community members. It's very similar to whether you drink tea or coffee or water or juice, and then how you make your coffee. Do you prefer cream? Do you prefer it black? Do you like medium roast or dark roast? Warm, hot, cold? We all are individual beings, uniquely created, and we have our own path, our own health status. All these different things have informed the way we are. Not only genetics, but our environment, our social determinants of health, our values and beliefs, all those things really help us craft our own thoughts about our health status. And so thinking through those for yourself, I think helps you better sort through and help people identify that for themselves as you're working with them. It used to be that we only talked about these type of really kind of complex decisions when we were looking at end of life. We were thinking about this new thing called palliative care, and should someone be palliative care or hospice? Well, what's quality of life and what matters most to them? But really, the truth is, we should all be thinking about what matters most with every single decision. And you can even take it outside of your health journey, right? You can apply it to financial decisions or family dynamics and things like that. But we really need to start people thinking about what matters most at every touch point along the way. 60% of people say that making sure their family is not burned by tough decisions is really important, but that it's very hard to do. 56% have not communicated their end of life wishes with anyone else. The bullet is it's time to transform our culture by communicating and thinking about what care we want and don't want for ourselves. And we should each have that opportunity to voice or discuss our decisions for the type of care, treatment, and services that we would like to have. So just for a second, I wanted to use the example of surgery and why we worry about surgeries with older adults and kind of apply that to our what matters most thought process. With our increase in population, we know that 55% of surgeries are performed on adults over age 65. And there's a huge risk versus benefit ratio that shifts to favor older, more complex adults, meaning post-op morbidity and mortality, so complications and death, are still higher than young adults, and those complications are usually worse. So think about the knee replacement and future falls on that knee or future infections, things like that. Older adults should have more individualized and multidisciplinary care, thinking through the consent and whether what the risks and benefits of the procedure are and whether it makes sense to do the procedure in the first place. The chronic conditions that older adults typically have, the drugs that we use often increase the surgery risk for complication or death. Just think about how our bodies change as we age and we lose more muscle, and how drugs work differently. So things like anesthesia or perhaps pain medications after the fact. Maybe we have difficulty sleeping after the fact. All of those things have to be considered when we think about whether a particular surgery makes sense for a person. So what we try and teach and follow in the healthcare field is that surgical decision-making should really be goal-oriented care. It does take some care planning. One of the stories I always use is cataract surgery for older adults. I would see older adults who live alone in the community and may have some arthritic problems where they don't have the fine motor movements to put eye drops in their eyes, and they would be scheduled for cataract surgery and very excited about it, as they should be, but there was no plan for how they were going to start the pre-op process and then finish that drop process post-op so that they could have the best outcome for their eyes. And there were some cases where we would actually have to put someone in a respite at either an assisted living or skilled nursing facility for that time, just to make sure those drops got put in the eye at the correct time, the way they were supposed to be, to make sure that they had the optimal outcome for that surgery. But it takes someone thinking through all that. We can't just blanket prescribe these surgeries and procedures for people without thinking through how they're going to do them and have the best health outcome. Life expectancy is always a consideration, as well as informed decision making. People have the right to make their own decisions. Sometimes people don't have the capacity to make their decisions, and that has to be decided on the front end. And if a person needs a procedure or a surgery that they're unable to make a decision about, then we have to kind of go down that path of surrogate decision makers or whoever has a power of attorney and talk about those risks and benefits with them. But we have to provide that same informed consent process all the way down the line. And in part of that process, there should be preferences for life-sustaining care. It's, a total knee at 95 with end-stage terminal cancer, end-stage renal disease, where a person's kind of mostly bedbound anyway, looks a lot different than a very active 72-year-old who's still out riding bikes every day or exercising. Not that it may not still be appropriate, but it's something to think about. And this comes into play a lot with preventative testing too for older adults. When you think about colonoscopies and mammograms and all those different things that we're supposed to have to prevent chronic disease or illness, we also have to think about what we're going to do with those answers and if it makes sense to do that test in the first place. So this is another opportunity for the chat. Let me look at these last. Interprofessional teams. Ooh, trauma-informed providers. That's very good. It's so hard to get good behavioral health and trauma-informed care, but it makes all the difference in the world. So most of you have what I would expect. Faith-based teams are also very important as well. So for this question, I wonder what makes you the most uncomfortable about having a what matters most conversation. And this could be if you're trying to have it with a spouse or a child or a parent or a patient or client that you serve. What makes you the most uncomfortable? It makes you not want to have that conversation. While you're entering it in, I'll tell you that one of the final straws when I left private practice to come work at UTC was spending a day where I just had patient after patient asking me about medications or procedures that were not appropriate for them. So think about, pain substances or anxiety medications or ADD medications. They all have a time and place, but it was just a day where everything was a fight. And so those are really a great time for what matters most because there are so many consequences to controlled substance use. There are also so many consequences to uncontrolled pain, and that needs to be a whole path that's gone down and investigated. But it takes the time and the patience to go through it. Driving is when it's time for somebody to give up their keys is an incredibly difficult decision, not only for the family, but whoever's trying to provide the evaluation about that. And I always try and have that conversation kind of up front as I met older adults saying, there's going to be a time and place when we're going to say it's time to stop driving. And we need to keep talking about that because we want to know what matters most to you. Is it church? Is it your volunteer work? How can we continue to get you in those activities if you're not physically capable of driving anymore? And you'll see a list there of all the different things that can bring about these conversations that are complex and require that thought and time and patience. I did want to address the burnout the resources in the burnout. One of the things that healthcare providers specifically, and I'm sure anyone that works in service industries, it's really difficult to enter into a conversation or some type of appointment where that a person needs a particular resource or service and you either A, don't know where to get it, or B, know that it's not offered or that person is not going to be able to access it. And a lot of providers will avoid the conversation to keep from having to either say that or having to address what we're going to do instead. There's evidence on that. Several years ago, probably in the early 2022, there was a big report from the Alzheimer's Association on primary care providers, and they're offering memory screenings, which is supposed to be done in every annual wellness exam. And only 16% of Medicare patients reported being offered a memory screening. And a lot of that falls back to that concern about, I'm not sure how to diagnose. If they are diagnosed, is there anything to do about it? And then where do I send them? So we're working really hard on, particularly with memory loss, on that early diagnosis and intervention piece with that education for healthcare providers and trying to identify those community resources so we can eliminate that fear of not being able to serve someone appropriately. And all that leads to burnout, right? It doesn't matter what discipline you're in. It doesn't matter if you're in your role as a caregiver or a spouse or a mom or a friend. we can all get burned out when we're dealing with complex, heavy situations all the time. That's one of the benefits of the interprofessional team, though. Being able to have a team who helps share that burden, you can bounce off ideas, think about out of the box resources, things like that. That's one of the primary benefits of bringing in an interprofessional team when that's possible. So I'm looking back here at the chat. It is important to listen with an open mind. Ashley asked, did they notice a difference with disciplines with the or avoidance of discussions? That's a great question. I looked at it some over the past week. Most of the research that's been done has been done with physicians and medical students, but it would be interesting to see if some of the other disciplines have that same issue as well. I suspect that more disciplines will, particularly in the area of early diagnosis with dementia and Alzheimer's, because of the new medications that are out, specifically the lecanemab. It has to be identified early. It's for mild cognitive impairment, and there are lots of different things to think about, including potential side effects, that risk, benefit, then the financial piece, and then the where to get it piece. And that really does involve kind of a team approach. So that's just one example of, we may get some more information in the coming years on how that all goes.
I'm interested in that because I was on a webinar earlier this week with primary care, and they shared some of the findings where like nurse practitioners and PAs were more likely to serve underserved patients or who had higher SDOH needs versus medicine. And so that's how, I guess their study was. And then what you're talking about, the avoidance, we've heard that from a lot of our different speakers over the course of these webinars. Particularly, we'll hear our doctors don't want to ask because they don't know how to resolve it, which is culturally part of medicine where, I'm leading the team. And I just wonder that maybe that's new research that needs to be done, but I'm wondering if, we're okay with the unknowns in other disciplines.
For sure. I think that's a huge point on a call to action, is just, I'm not sure the right word is advocating for, but getting involved with trying to find those answers, but also promoting that awareness, I think is probably the best way to frame it. We have to promote awareness of these issues, but also offer some of that education. People that have been trained in a discipline, it doesn't matter whether you're a plumber or electrician, things change. And so as people were trained years ago, even 5 years ago, you have to stay up on your evidence-based practice, and that will help with some of these conversations because it also will help you identify some of those resources too. So a lot of that is really encouraging. And I think that helps burnout as well. When you are always kind of striving to know more and learn more, it helps you figure out what's out there and how you can integrate that, whether it's systems practice or, specific healthcare practice or, gas versus electric vehicles. So this just speaks again to that, the role of healthcare providers. And obviously, we just talked about evidence-based practice, making sure we communicate. Someone mentioned in the chat about communication and listening. That decision-making capacity is going to continue to just come up all the time. We want to absolutely be sure we're involving caregivers, but when all else fails, listening is huge. A mentor told me a long time ago that people just need a plan. They understand that you may not have all the answers. They understand that we might not be able to give them their life expectancy or their prognosis, especially that day at that time. But they can understand too, if we're able to listen and give them a plan, it helps them process through some of that. And I think a lot of it is putting yourself in that position and thinking about the questions that you would have, and then recognizing that a lot of these complex situations require processing or more information and then circling back. These aren't one-off conversations. These are over the time of building relationships with people, building relationships with families and caregivers, and trying to look ahead and spearhead some of the things that you know will be on the horizon. That's one of the most important ways we can support caregivers. The biggest gift we can give our loved ones is to tell them what our wishes are and what matters most to us. Those who give care, some don't necessarily do it because they want to, it's because they have to. There may be family dynamics or things that have traumatized them in the past. We have to be willing to recognize that and support people where they are. But there are others who that's their life's calling. And so each caregiver is different, just as each journey is different. And so we have to help them meet them where they are and help them meet those barriers as well. Some services are really hard to find. Respite's almost impossible in our area of the state. And finding community resources is a daily, if a weekly, if not daily thing that we're trying to identify to help people. But there is, a big piece of legal and financial considerations that we can prep people for. We can prep people, even as individuals, to start figuring out powers of attorney, both for health and financial, thinking through advanced care planning. Those are all things that can be done as soon as someone turns 18. And really, there are tools out there for children on some levels as well. This brings me just to a couple points about ethical considerations, because we're going to switch and do some tools here. But we always have to respect autonomy. People have the right to choose their care for themselves. And sometimes that can be very frustrating when we do have resources and they don't want to take advantage of them. And then we talked a minute ago about informed consent, capacity, and end-of-life care. All of those things, again, are easily approached with more easily approached with an interprofessional team. But they're things that we have to consider. Some of the barriers to having these discussions include a lack of evidence. Maybe I don't know if this medication is the best for someone in their particular situation. Maybe I don't know if one hospital system is better than another. I'm just trying to pull examples out. But also prognostication is hard. We do our best to say, days to weeks, weeks to months, months to years. But we're not always correct, and that's hard. Balance of power is difficult, especially in a team environment. A team should have all equal parts. A doctor is as equal as the chaplain. That's the way that the team works best in collaboration. But patients also feel that balance of power, especially my parents and my in-laws generation. It doesn't matter what a health provider says. It is absolute gold, and they place that above their own personal care preferences. So we have to really watch how we frame conversations and information on treatments to kind of put that back as options to whoever we're serving, so that they can make an informed decision on what they prefer. Okay, let's switch to a little bit of practical applications. A lot of you may be saying, well, that's all wonderful, but this is, controlled by my organization. I don't have enough training. I don't have the time. We have accessibility issues. We have a facility where there's no elevator, aren't age or senior friendly. They don't want to do quality improvement initiatives, or if they do, it's centered around children or, sexually transmitted diseases and not older adults. And I think as we continue to start promoting, or as we continue to promote awareness of the needs of older adults and caregivers and the importance of building our community infrastructure, we will have voices that change a little bit and be willing to focus on this approach. This is a lot of words, and it's a quote, and the article is at the bottom. It's on patient-centered care. But I wanted to call your attention to a couple things that it says. The first part is healthcare organizations around the world tend to focus on the needs of their physicians and staff rather than their patients. And they believe that contributes overall to the health and well-being of the public. and their patients. But unless they are actively partnering with their patients to understand what matters most, they will not achieve the outcomes they desire. And let's see, somewhere in here. Okay. Clinicians rarely experience the frustrations and challenges of getting care until they or a family member needs care. And I think that's true for all of us. Unless we've been sitting in that position, even those who do this work day in, day out, until you've experienced what it's like to take care of children and someone with dementia at the same time while trying to work, while trying to, run errands, it's just the hardest job a person does. And many times it's really difficult for clinicians to understand unless we've been there before. So these next two, there's two schematics here. One is the 4Ms and how it applies to hospitals and some of the things that you can do to help provide age-friendly care in the hospital. This one is about outpatient clinical practice. I put those in there, but we're not going to spend time on those. I did want to bring up, because I know a couple of you are in the pharmacy field, the Beers criteria. There's one of the tables in the using wisely, a reminder for on-time proper use from the American Geriatric Society. And there are things in here that, again, I just wanted to call your attention to when we're thinking about that risk versus benefit. The first bullet point is medications. And by the way, there's a more recent criteria, but this was just something I found to help prove my point. Medications are potentially inappropriate. They're not definitely inappropriate. It's recommended that we read the rationale and recommendation statements for each criterion. There are caveats and guidance, and those that are listed are important. We want to understand why medications are there and adjust our approach accordingly. So all of this to say, a lot of great work has been done on this. There's a lot of evidence-based practice mixed into these, but it doesn't necessarily mean that it's the end all. It's absolutely the guidance we should give our best effort to adhere to, and there are reasons behind it. But every patient is different, and we have to think about the scope of that, both when we're looking at deprescribing, getting rid of medicines, or before we start to try and prescribe something, especially if someone's having complications. Okay, so one of those ethical situations for shared decision-making, that's what that SDM means up there, is for the unbefriended. So unbefriended are those who don't have family or haven't identified a caregiver. They may live alone, but they don't have anyone that makes decisions for them. I put this in here so that you can read it later, but medical decision-making for unbefriended older adults has to include a certain segment of safeguards to make sure that we're approaching care fair and from the what matters most perspective. It's recommended that we use non-traditional surrogate decision makers, that we make sure and assess the decision-making capacity for that person in a systematic way, so that wherever that person goes in the healthcare field or in the community, we're all on that same kind of level playing field. Capacity is a monstrous issue that would be several of these collaboratives. But this is just a set to get you to think through some of the red flags when someone's unbefriended, how we need to make sure that we're meeting their care preferences as well. Now, a little more specifically. So there's something called journey maps. Because we know that the highest risk factors for mortality, functional decline, and institutionalization are these: age, cognitive impairment, functional dependence, malnutrition, and frailty. There are maps that as a system help us identify the places where we're likely to have issues, right? This first one that's in the presentation is a typical healthcare scenario of an older adult who has fallen, needs surgery, then needs help with transportation after the fact, as well as activities of daily living assistance. And then there's a workforce shortage and all the bad things have just happened. It's a perfect storm. which is actually very, very common. So this little journey map here outlines all that, and it's meant for organizations to look at a system-based approach. And I was hoping you all would look at it for a second and just think about what type of intervention you could suggest to help one of these bad things keep from happening, to prevent something bad. So an example would be, well, I'll choose the easy one, the lack of programs to help older adults understand their insurance and coverage. This is very, very common. People will choose Medicare plans or straight Medicare without knowing what the impact is on their medications. And I'm not saying they're doing it on purpose, but they don't realize that there's a difference. So making sure that we promote the availability of services that can help older adults figure out what coverage suits them best for their particular health needs. So that's one thing in that kind of system of care. And please feel free to either unmute and talk a little bit about all this or put it in the chat. Either way.
I guess I'll break this down. Let's go first. Just piggybacking off of what you said with the insurance, there's so many programs that are available but difficult to use for patients to access their medication, whether it be manufacturer assistance programs or, I mean, now coming up into, let's see, 2025, we'll have the out-of-pocket smoothing. That would be an option, but it's so complex. Every time that I ask somebody about this, like in this space, they can't even explain it to me, let alone us explain it to an older adult and they enroll in it. But it would be so beneficial. And if you look at the evidence, that's what people are saying they would prefer, is to have capped monthly spending for prescription medications. So, I mean, I think there's a lot of, I think people, my parents included, like if they go to the pharmacy and they're like $300, nope, I'm not taking that. And they'll leave.
Exactly. And instead of a call being made back to the provider, they wait and go their next month or 3 months down the road. The provider has the expectation they've been on that medicine, but they haven't. And so now, you know, bad things may have happened, they may not have, but either way, their care is not optimal. So this is an example in the green of if this in the future was handled better across all those different touch points. So part of it is that when the person hit the ER in the first place, the hospital staff inquired what matters most. The person was moved to surgery quickly. There were enough beds and caregiving support. They were aware of their insurance benefits that included some care coordination, and that was started prior to discharge, including things like transportation services, in-home care. Then there's also some falls prevention for local community to promote awareness and prevent falls. So this is just something for you all to think about as you go through your work, about how you can map someone's kind of bad situation and work towards advocating or systems process that help prevent that for them or someone else in the future and their better health outcomes. And it all kind of starts with what matters most to them. Two other decision guides I want to show you. This is small print, but you'll get the PDF of it in the email after the fact. But this is just a discussion on medication to treat high blood pressure. And these forms are made for depression, for back pain, not a lot, but a host of different common things that a person may be seen for with their primary care or another provider. So this is basically talking with the person about what they understand. And actually, I've got it backwards. If you look on the right, what's the issue? Your blood pressure's high, and why is that a problem? And there's the explanation there. And then here are some different treatment options. And it steps the provider through. No treatment at this time. We think we can do some lifestyle modifications, or we think there's medicines that are necessary. But at the bottom, it reframes what's most important to the person. Is that reducing stroke? Is that minimizing disruption? And then what the decision was, or what we're going to decide later, and then what the next steps are. So that person has a copy of this in their hand when they leave, or at least it's written in their care plan somewhere that they get. But then it goes a step further on the left and actually talks about each medication. So these were created basically to help prompt the providers with all the different treatment options, the risks and the benefits, to give that person that decision-making capability on what they want to do about their problem, to make sure they understand what their options are. These are available. Like I said, I'll send the link, but you can pull those up. The last thing I wanted to go through with you was the conversation project. And again, it'll be linked, but there are free guides here for all sorts of things. And different organizations do this, but this one is through the Institute for Healthcare Improvement. I like it because it has resources for healthcare, it has resources for faith communities, for community resources, guide for talking with a healthcare team, being a healthcare proxy, choosing one, and then the conversation starter guide. And that is a longer document that serves a purpose if you're really trying to have a long conversation with somebody, especially if it's like a family member where you just want to walk them through the questions, because a lot of times family members just say, I don't know. So this is another great resource for you to consider if you're struggling with some of those conversations. And I know we are right up on time. There's a case study in here that is multiple slides, but it's here for you. You can go through it on your own and think through those. But that concludes everything I was hoping to cover today. I've got to stop my share.
We will share the slides with everybody attending here today. And just as a reminder, this will be available posted as a webinar on our website. But I do want to open it up for questions if anybody has any for Dr. Wick. I've seen a lot of these. Great interaction in the chat.
I will go first. Dr. Witt, I just want to say this was absolutely awesome information. I am a CNA, but I'm aspiring to go back to nursing school.
Do it.
I know, right? And I think that you are the first person or the best person to learn from and to get information from. So is there a way that you have an email, or I can kind of email you some questions or something?
Absolutely. So I just put my email in the chat, and I'll give you kind of our website too. We have a couple of our programs going on in the community, and that'll help drive you back to me as well. But I love to mentor also, so I'm happy to answer any, and I get questions all the time about different things. So I appreciate all of y'all participating, and I can't wait to go back and read. I think I got most of the chats read, but I can't wait to go back and read them.
Yeah. I see applause in the audience, and Shalizia, yes, please, we need you in Tennessee to be a wonderful nurse, so we support you all the way. Please let us know how we can support you. Does anybody else have any questions before we go? Wonderful presentation. Okay, perfect. So we have Dr. Wick's email address in the chat. This webinar should be posted within about a week, and her PowerPoint slides will be coming out to you. Thank you so much for joining, and we will see you next time. All right, thanks. Bye-bye.
Bye-bye.
We hope that you've enjoyed today's webinar. For more information and resources, please visit our website, tnhearthealth.org. You can find more webinars under our resources page. You can also follow us on Twitter, LinkedIn, and YouTube. Please let us know if there are any specific topics or speakers that you would like us to present. Lastly, tell anyone you know who would be interested in helping to decrease the burden of cardiovascular diseases in Tennessee, and share the webinar. Together we can achieve our goals of managing and preventing heart attacks and strokes for Tennesseans.